As my friend Marty McCary likes to say, billing quality is healthcare quality. It may not be the exact representation of how he says it, but how we bill patients is important to the overall delivery of care, because we don't want to prohibit people from doing what is important for their health by having sticker shock.
A safe haven for innovators to go off the rails. Welcome back to the Off the Rails podcast, a show about the runaway train that is our healthcare system and the innovators working to derail it. I'm your host, Sydney Haytoff, and today I'm joined by David Balat. David, thanks for joining us.
Thank you for having me.
David, I'd like to start off with a little intro. Tell me a little bit about yourself. So what is your current role and who do you work for or with?
I work for myself. I'm the founder and CEO of Healthcare Finance Specialists. It's a consulting firm mainly made up of me and some of my friends who are long-standing careers and are experts in their field pertaining to making healthcare more accessible and affordable. One of the projects that I'm working on right now that I'm very excited about is I'm working with a hospital system in Texas that is interested in bundling their prices and making them available upfront for direct-to-employer models. So going to large employers and saying, here's a hospital that is willing to work with you on your self-funded plan. What incentives can we produce for your employees to have them use this facility and drive costs down for you while also giving them a quality product?
Love it. We're going to dig into that in a bit.
Yep, we'd love to.
What's your favorite food? And do you have any pets?
Food, I don't discriminate. I'm Mediterranean, so that's my go-to. That's home cooking for me. So that's probably my favorite category of food. Pets, I don't currently, but I have had several dogs, boxer dogs. So that's definitely my favorite breed of dog. Yeah, that's it. There was one other one, I believe.
Love boxers. What is your perspective on direct primary care?
Well, I use it on customer. It's superior. It's a fantastic way to interact with a physician and have a relationship with your doctor. I've been a direct primary care customer now for 7 years. And, what's interesting and what I've even learned about it is it requires retraining. It requires a new way of thinking about your own health. And as I'm getting older and facing milestones with regard to age, I'm 51 now, you tend to think more proactively and work with your direct primary care doctor to address things before they happen or right at the onset of things happening. So that's the real benefit, because that runaway train that is our healthcare industry, unfortunately, it's a reactive system. It's a sick care system. It's not a healthcare system, whereas direct primary care truly is healthcare because there is a reimbursement model there that addresses proactive care. And that just doesn't exist in our current industry.
Amen. Let's dig into that. Direct primary care, subscription medicine, essentially a prospective payment system to some extent. Would you say you're paying for the services? They're bundled?
I prefer to use the word proactive. I don't like that. That's too similar to the prospective payment system that Medicare uses, and I don't want to tie anything associated with CMS to direct primary care. So I have a visceral response to when you use that language.
That's fair. Yeah, I use the word prospective because from what I've seen, even the concept of bundling care and bundling procedures is something that has come from, I don't want to say Medicare, but is a system that Medicare has adopted in the past. And so although I agree with not conflating the two, I do believe that there is enough of a history rooting in some of the pre-existing payment mechanisms that helps or could help bridge the gap for people that don't necessarily understand the new age payment models. Does that make sense?
Yes and no. It makes sense, but do I necessarily agree with it? Not really. I don't think this is necessarily a new way of paying for healthcare. This is actually a very old way of paying for healthcare. It's coming back around. It's cycling back around because the managed care system, the HMO system, it's failing us. So we're seeing more and more research come out. I think I saw something from the New York Times today about how cash is superior for lower level care like primary care or labs or simple types of imaging modalities. Cash is always a better payment model, and having that cash available to even the poor. We tried in Texas, a bill that I worked on was to divert some of the premium dollars that went to Medicaid managed care into a card that the Medicaid beneficiaries could use on a voluntary basis for direct primary care. And the biggest fight was between me and the insurance lobby, because they were not going to give up any of their revenue. But we could talk about that later. But even the prospective payment system from CMS, that's insurance. It's a form of coverage. And one of the biggest things I think I'm probably known for is the statement of coverage isn't care. We've got to stop conflating health insurance with health care. Because when you hear politicians in DC talk about health care, they're not talking about health care. They're talking about health insurance. And we've got to be able to separate those two and understand what one is talking about when they're saying conceivably the wrong word.
Yeah, I totally agree with that. And I think the concept of coverage has been perverted. I definitely agree with the wanting to distance the two, but to some extent, direct primary care is primary coverage, right?
No, not at all. You're paying for service.
Well, you're paying for a grouping of services, which is why I was referring to it as like the prospective payment system. You're paying monthly subscription for unlimited access to your doctor.
Would you call your Netflix account something similar to coverage?
Yes, it's coverage that allows me to view content.
I guess it's a matter of interpretation. There are a number of states that have passed laws carving out direct primary care because they recognize that relationship with the doctor that you're paying a monthly subscription for is not the same as insurance, and therefore not under the regulatory authority of the Department of Insurance for that state. They recognize that. So no, I don't believe that it's a form of coverage. They're not taking on any risk, because if something bad were to happen, what risk is there? And that's by definition what insurance is, right? So I think if we look at it that way, we can rightly agree that it's not a form of coverage or insurance.
Yeah, I don't think it's a form of insurance per se, but doctors are taking on risk that patients might overutilize their services as compared to others.
Is that a risk?
I mean, I think by definition, that's a utilization risk for sure. I don't think there's much of a financial risk.
Yeah, I think that's a question for a direct primary care doctor. I don't know that they would say that. I don't know that they would say having a patient come in every day or talk to a patient that's chronic in nature. And I'll tell you this, one of the biggest arguments against direct primary care, people will say, well, they're just cherry picking their patients. They're just picking, healthy, rich people. That's not the case. Oftentimes it's people with lower middle class, and they're chronic disease patients because they will pay extra to see and get the care from their doctor on a relatively frequent basis. And so those DPC doctors are taking care of very sick patients. They're not cherry picking whatsoever. So the increased utilization is just it's more par for the course than the exception. So is it a risk? I don't know. I think it's part of the model.
I definitely think it's part of the model. Definitely agree that there are a lot of people who are higher utilizers than others that are utilizing DPC, and that's the reason why they do it. It's the reason why I'm a huge fan of it, is because there is no rationing of care like you see in the perverted coverage models that insurance dominates and administers. But I think that I guess what I'm getting at is we can call something coverage and still make the distinction between good coverage and bad coverage. I think coverage is covered.
I think we're going to agree to disagree on that.
Okay. That's fine.
And the other thing that the DPC doctors do to accommodate that, knowing that there's going to be probably increased utilization for people in increased age ranges, is they often charge a little bit more based on that age band. So if you're 60 plus, you're going to pay $10, $15 more a month with the knowledge that there's going to be increased utilization.
And still agreeing to disagree, but from my perspective, they're adjusting for the risk of utilization risk for those patients with that monetary increase.
You've mitigated that. If we're going to use that word risk, you've mitigated any risk. But again, I think this is a question to have with a DPC doctor, because what's their mindset? What is their understanding? I'm happy to be wrong. I just also disagree.
Yeah, and that's fine. That's the beauty of these types of dialogues, agree to disagree, because I think we're still in the early stages of people's understanding of what direct primary care, what subscription care means. And I think we can choose to categorize it or define it differently, but at the end of the day, high level, it's one thing. Question in the context of DPC, what happens when you need to see a specialist? What does that look like?
It depends. It depends on your DPC practice, because many of them are bringing on specialists, so it could be a part of your subscription. I have seen in other practices where they will go out and meet with various specialists and say, look, my patient is a cash patient, or my patient doesn't have insurance, whatever the case may be. But I've seen this particularly. One doctor had a newly diabetic patient, and he called the endocrinologist and negotiated a cash rate for a telemedicine call, had the telemedicine call with the patient in that primary care office, and was sitting next to the patient when they were having their visit with the endocrinologist. So that's just one example. They're not all like that, but that's the kind of, that one example is an example of the kind of care and hands-on approach that a DPC doctor will give. But many of them have gone out and done the work in advance to say, okay, I like this orthopedic surgeon, I like this endocrinologist, I like this dermatologist. They have given me upfront pricing, so this is what you can expect.
And is that upfront pricing for the entire fee schedule, or is it for a consult? What does that look like?
Typically, it's whatever it is. It could be for a procedure, it could be for a consult. Typically, there's oftentimes not a surprise when you're getting a referral from that direct primary care doctor, because they do their homework. And, in one of my visits, the last 10 minutes of the hour-long visit is, okay, well, I've prescribed you these medications. You can go to this location, and this location for these prices, and this is what your out-of-pocket's going to be. So it's, as my friend Marty McCary likes to say, billing quality is healthcare quality. It may not be the exact representation of how he says it, but how we bill patients is important to the overall delivery of care, because we don't want to prohibit people from doing what is important for their health by having sticker shock, or really, what's more the case, the ambiguity and the not knowing.
Amen. Yeah, financial toxicity, what he refers to as the result of the unknown and the uncertainty around pricing in our industry, it leads to treatment abandonment and people not getting the care they need. And the downstream effect of that is clinical implications and clinical toxicity. And so I totally agree with him there. Yeah, it's interesting. I've seen the same concept where direct primary care docs have their referral network, as any doc who refers out to different specialists. And in some instances, they have, a couple of consults, maybe an x-ray. The reason why I led you into that question is because I think what's largely missing in those contexts, and where we've been able to plug the gap, is a full breakdown of what to expect with regards to pricing when you're referred into a specialist for a particular procedure or a consult, whatever it may be that the referral's made for. Yeah, it's been great to see that mechanism is starting to be used and catching on more widely, the cash pay ecosystem.
And I mentioned earlier about how there's been some retraining on the part of the patient having to be had. And that's a great example. When you're sent to a specialist, if they're saying, well, we need to do this, and this, or we need to do these other tests, or we need to bring you back in for another consult, or whatever the case may be, I've learned to go back to my DPC doctor. I would say, well, what is the price for that? What is the cash price? You have to be an engaged and active participant in your healthcare. The days of saying, yes, doctor, are gone. It sure should be. It's okay to have a dialogue to say, what is the cost? What is this going to run me? What is the upfront cost? And if they don't know, go back to your DPC doctor and see if he has somebody else in his network that can give you that information, because that's critically important, as you mentioned, getting the necessary care, because again, the unknown is preventing people from doing what is necessary.
Yeah. Surprises kill on both ends of the spectrum. They'll kill you financially and they'll kill you clinically, because the fear of the surprise bill keeps people out of the doctor's office, and it's a matter of life or death. So yeah, I think that's that.
But the responsibility is also ours. We cannot be passive in this ecosystem anymore. We've done, many people will blame insurance companies and the government and pharma and PBMs and physicians and hospitals. But you know what? Patients are just as much. We have abdicated our responsibilities. We have abdicated our position to ask questions and to question the authority or get second opinions. With more physicians now being employed by hospitals, that's also created more of a problem where it's difficult to find an independent doctor. So asking for a second opinion is maybe more necessary now more than ever. And I know that's probably not going to be a universally popular opinion, but it's mine.
Yeah, no, I think it's always good in the matter or the context of health to get a second opinion. It's always good with any informed decision that you're going to make that's going to have, financial implications, clinical implications, to make sure you have all the information so you can make an informed decision and do the right thing for yourself, for your family. I think to your point about retraining people, I think, and then coming, from my perspective as a millennial, we've been trained and wired to expect the system to give us the information. And that's a very different experience than we've come to expect in pretty much every other industry, where we're accustomed to and expect to be informed consumers and informed decision makers that are very much a part of the decision making with our guides, our clinical guides, our athletic guides, whatever type of guide that we're utilizing. It's a communal process. But in healthcare, traditionally, I think we've been wired to, like you said, do what is ordered, get the treatment that's ordered, go to the doctor that has been referred without asking questions.
Right.
And as much as I wholeheartedly agree with your point that we need to be more informed consumers, I think there's going to be a bit of a, yes, it's a learning experience and a learning curve that we need to go down and help patients go down. But it's a deep one. It's way deeper than I ever expected it to be. And as someone who, we started out, Mishy's offering as a direct-to-consumer offering, giving patients access to transparent discount prices, through our platform from providers that are on our network. And seeing the decision-making and seeing the interaction with the tool, made it very clear that people aren't necessarily ready to act on information in that way in the healthcare context just yet. And so we decided to tap into the referral mechanism and tap into referring providers, DBC docs in general. And it changed the nature of our traction and of the adoption of our platform. I think that's because people are looking to their trusted advisors to help them make decisions. And I think to a great extent, the clinical world, they don't have the tools that give them a sense for what a service may cost if you're referred outside of the walls of the facility that you're in.
I think there's two reasons for that. One, when you're going to your doctor, you're not feeling well. You're in a vulnerable state. All you want to do is feel better so that you can go about your life. So that's one of the reasons why it's difficult to want to make those decisions and go through a learning curve when you're not well. The second reason is the system is too damn complicated. It is, I've been at it over 30 years and still I learn things every day. So it's a real challenge. It's needlessly complex. So having a physician, a DPC doctor, or just an advocate of any kind, and I function in that role for a number of people, it's helpful. People need a guide or a Sherpa, whatever you want to call that person. But it's always best if that's your primary care doctor.
Yeah, navigators, I think.
Navigators, yes and no. They're not as connected. You don't have a relationship with that navigator. It doesn't hurt anybody who can guide you and point you in the right direction. That's fantastic. But to level up, that's somebody who knows you as an individual, what you like, and understands your history and what you are capable of and what you're not capable of.
Yeah, I think you're right. That longitudinal view of the patient is missing from care navigation. But yeah, as you said, it's still helpful for them to navigate or to be able to tap into to navigate the complex system, because there's just too many variations and pieces, especially when you consider insurance coverage, not being covered by insurance, going the cash price, who's going to accept cash for care. I think we're starting to see the shift towards the cash pay ecosystem, but it's been interesting to see from my perspective, a lot of docs that are still, primarily insurance based, some of them out of network, but getting checks from insurance companies in the out of network context. They're concerned about taking cash and marketing cash prices. And I know it's something that you and I have talked about in the past, this concept of having two prices for care. And even if it's not necessarily two prices, accepting or having a different cash rate for someone who's uninsured versus someone who's insured. Yeah, I think docs are still trying to find out ways to navigate the state level regulations that exist and do so and participate without exposing themselves to scrutiny, whether it be by their insurance carrier or their state insurance board. I know you have a lot to say about that. Let's dive in.
I do, yeah. I think cash rate is not another price. It's a negotiated rate between the provider and the patient. There's not two sets of books. There's one price, and that's that gross charge, that price.
Charge master.
The charge master rate. There are different negotiated rates based on insurance company, or there are different negotiated rates with employers. There are different negotiated rates with individual patients, and that's what the cash price is. Whether you have insurance or not, even if you have insurance, you can ask for the cash price before you give them your insurance card. They ask for insurance, they'll say, what's cash price? Oftentimes, if you know what the negotiated rate is, which I recommend that everybody know what that is for a particular test. So my favorite example is the CAT scan. If you go to, regardless of the market, it could be anywhere from $700 to $1,500 for a CAT scan. Well, you can get one cash for $250. And if you have a $5,000 deductible, of course, you're going to pay cash. Now, the only problem that most people run into is, well, that $250 or whatever I pay cash is not applied to my deductible. So they feel like they're missing something. But are you going to hit your $5,000 deductible? 80% of people in this country never hit their deductible, according to the Association for Health Insurance.
I've screened that at the top, the top of the rooftops. Yeah. So yeah, keep it going. Yeah.
Yeah. So what does that mean for us as patients? That we're functionally uninsured and that we're cash patients. And if we're cash patients, shouldn't we look for the best price?
Absolutely.
It really is as simple.
It's a no-brainer. Yeah, and I love that you said the cash price is a negotiated price and a discount rate, the same type of discount that is applied to an insurance claim. I think that viewing the cash price in that context and not viewing it as its own separate transaction, as long as doctors are applying the same type of accounting mechanisms that they apply to insurance-based services that are rendered and the invoices that are submitted to insurance carriers, that would and should prevent them from any harm, prevent them from being seen as having two fees.
It's like it's not. It's not another set of books. It's essentially a single use agreement with the patient. And you take your money, you apply that payment, you have a contractual adjustment off your price, and that's what you need. That's all it is.
Yeah, and as long as docs and practices are able to implement those single case agreements, then everyone should be fine. I think from what I've heard, the concern is the scalability of those agreements, just given the nature of the granularity of services that a doctor could provide to a patient at any given point. And how does one apply the appropriate discount in a standardized way for the hundreds of services that they could render at any given point in time? How do they process that at the front office without creating any friction or abrasion for the patient or for the employer that might be covering that service?
It's really not that much. If you go into any particular specialty office, there's 30 to 40 different things they do, and there's doing the hard work up front of establishing prices for those things. In healthcare, physicians and facilities need to embrace the bundling of charges instead of having everything unbundled on a CPT basis, particularly for cash transactions.
Yeah, and I think bundling does help make things easier. But I guess when we've bundled services, it's usually across different care settings. So you're bundling a surgeon's fee, anesthesia fee, the facility fee, the implant fee. It's still pursuant to one single procedure, but yes, obviously it does make it easier because you're not having to invoice, 4 different parties, pay 4 different parties. It's one bundled payment.
That's a traditional viewpoint, but that's not always the case. I mean, you look at some hospitals, they have something called an executive physical, right? You've heard of those? Mm-hmm. What does that include? It includes time with the doctor. It includes a panel of labs. It includes maybe an x-ray or EKG, and it includes just a battery of tests, and there's one price for it. That's bundling.
Absolutely.
Yeah.
The limitation there is that, as you said, those are offered primarily through health system, through hospitals. And hospitals traditionally the cost centers of the system where prices are inflated for no reason. But I guess what I'm getting at is to enable for bundling to occur across independent specialties, independent clinical settings in the context of a surgery or in a executive physical, like you said, the ability to bundle each of those services in under one single price, it becomes a much bigger task. And to your point about docs in any given specialty rendering 30 to 40 services, I'll just give you an anecdote. I was right before this, I was looking at a breakdown of top procedures for an orthopedic specialty group, actually multi-specialty group in Texas in the Dallas-Fort Worth area. They sent me a list of over 100 codes, looking to get an understanding of what the appropriate reimbursement could be based on, a range of Medicare prices, 100 to 200% of Medicare. The point is that I think that view of 30 to 40 procedures and the view that it should be simple for the cash ecosystem to be implemented at the front office, it comes into conflict with, operations, clinical operations. I've seen it firsthand where unless you have a system in place to reference the appropriate price to collect from a patient, then you run the risk of not being seen as having those discounts being taken at a standard rate. And if that's the case, then you could be seen as having two different prices for the same service. And so it just opens doctors and practices up to, issues, whether it's from the insurance carrier or from the state board.
Yeah, no, I disagree. I don't know why it continues to be thought of as second price, but, you're talking about a big orthopedic multi-specialty group. Of course, you're going to have more than 30 or 40 because the 30 or 40 I referenced was the single specialty where you're looking at one particular type of specialty. Now, an orthopedic practice you're going to have spine guys, you're going to have knee guys, or joint guys. You're going to have some guys that focus on nothing but the shoulder, some guys that are nothing on the hip, or you're going to just have generalists. So, yeah, per individual specialty, you're going to have a reduced number. It's incumbent upon the people that do 15, 20 different cases to work on their cases. But if you're talking about a big practice or a big hospital, of course, you're going to have hundreds. But that, it's that old adage, how do you eat an elephant? Well, one bite at a time. It's not impossible. It shouldn't be impossible, and it can absolutely be done. I'm doing it with a hospital system in Texas, as I mentioned earlier. Is it a challenge? Yeah. Is it a lot of hard work? Absolutely. Is it going to be done? Without question.
Absolutely. I'm doing the same with our first hospital system in New York City, and we'll be replicating that with a few more soon after. But I guess the ability to do so comes down to tools, right? Even when patients come into the front office, they want to pay the cash price. The front desk person is looking at a grid to get a sense for what that price is based on what service they're receiving, whether it's an x-ray or consult or injection, et cetera. And so I think, or what I'm getting at is, without the proper tools, that's where it becomes hard. With the proper tools, doable. Without them, it's kind of, tough. Can't go to the moon without a rocket.
I think we're complicating something that doesn't need to be complicated. Is it easy? Is it like looking at a McDonald's menu? No, it's not. But it doesn't need to be like rocket science either.
Totally agree with that. I think it comes down to the tools that are available. I guess let's dig into the project that you're working on with the hospital. What does that look like? How are they planning to implement those? And I know you said it's for direct-to-employer arrangements, and that's definitely something that we've seen a lot more of recently. Huge opportunity amongst the growing self-funded employer space. And so practitioners and hospitals are incentivized to establish their contracts that they'll offer and take ownership of when partnering with local employers and health plans. What has that been looking like for you? What are the mechanisms that are in place to ensure that there is a streamlined billing cycle, that there is no financial issues, toxicity, whether it be for patients or the plans themselves?
Yeah, we're still at the beginning of this project, so it's still in its infancy. but it's a lot of coordination. It's a lot of communication. Hospitals are notorious for not having a lot of cost accounting. So to know at a granular level what something costs just doesn't exist in the hospitals systems in this country for the most part. So what do you have to look at? What's your baseline? Unfortunately, we have to use Medicare rates. Now, then you have to ask another series of questions. Does the hospital make money, or is it a loss at Medicare? And you have to establish some kind of decision-making metric to it to say, okay, well, we can't use, if we're running at a loss using Medicare, that can't be our base. We want to have what our costs are, or estimate what our costs are as much as we possibly can. And from that point, you look at establishing the same kind of discussions with, if we're talking about a surgery, with your anesthesiologist or the anesthesia group, with your radiology groups, with neuromonitoring, with your implant company, with the surgical assist organization. Whatever it is that you need to bring into that surgery that's normally done, that's standard of care, we need to be able to have them on board with us, because if we don't, and the patient is still getting 8 to 10 different invoices at the end of the day, we haven't accomplished anything at all. We have to be able to incorporate and include everything that is being done and have that available in that bundled price up front. And that's where we are right now. It's just knowing what our costs roughly will be, and then working with the various medical professionals that will be involved in the litany of things that are done in a hospital system, having them come together and say, okay, this is what we want to do. What's the advantage? What's the attraction for them? How are we making this look good for them? Well, let me give you an example that will hopefully tell this story.
And I can help if you need it, but
sure. A friend of mine that was as a broker working for an employer group went to one of the largest health systems here in the Houston, Texas market. And he said, look, I know that you guys consistently command 300% of Medicare for the negotiated rate, but the average deductible is $6,000 in this market. You're collecting roughly 45% of the deductible. Your effective collection rate is more like 150% as opposed to the 300%. What if we gave you a contract for 150%, no patient obligation, no deductible, no copay, no coinsurance? We paid you 100%. We paid you in 5 days. They said no. I think that's more hubris than anything else, because the people that we talked to, the hospital system that I'm working with, saw that, understood it, and jumped at the opportunity. They said, that makes sense to us. We would love to be a part of that. We would love to reduce our administrative burden and be a part of that kind of model. And when we go to these medical professionals, we're telling them the same thing. Wouldn't you want to cut down the amount of time with payment and be paid at 100% and not go after your patient? Would that be attractive to you? The answer is always yes.
Absolutely. I've seen the same thing. And that's what's made it fairly straightforward for us to scale our network at Michi, is that promise of same day payment. There's no reason, when you know the service that's going to be rendered, for there to be a back-end billing or a back-end adjudication process. Absolutely no reason for it. In no other space do you know what you're going to be receiving. Do you know what the cost really and what the price would be at the time that the service is rendered? And then you are forced to wait 3, 6, 9 months for payment when you're talking about surgical services, and have to fight to get that. It's insane, this retroactive billing process that we've been stuck with for the last 40 years. It's been bleeding the system dry, and it is the wedge into the systems, the facilities, the clinicians that are willing to play ball, willing to try something new, because it's fairly straightforward. Like you said.
And then there's the fear. There's the fear. The thing that you didn't mention that's also a concern to many doctors and hospitals and other facilities are clawbacks, because the insurance companies, even within an in-network contract, they have 6 months to conduct an audit, and they could come back at any time in that 6 months and say, you know what, we overpaid you because we deem this as experimental or unnecessary.
I've seen it over a year later, clawbacks for claims at $100,000 plus for coordination of benefits.
Yeah.
How absurd is that?
You know, especially in the self-funded market, that falls under the subrogation clause of the network. I apologize for it. It falls under the subrogation clause. And so the TPA or the network, what they'll say is that, well, we went back and we found this money. And because we found money, here, employer, here's of the $100,000 that we pulled back, here's 60% of it. And our fee is 40%. So we get $40,000 for recouping this money. Now, the employers are happy because they just got $60,000 back. And the organization that retained that 40% for finding that savings is extremely happy. Isn't it interesting now that insurers have really effectively not functioned as insurers? They're third-party administrators or whatever it is that they do now. They have a litany of different functions, and they're making more money. If you're watching their share price and looking at their market cap, they're doing phenomenally well. And that's by not assuming risk.
Yeah, they pretend to assume risk and then pass it on to patients and employers through or in the form of deductibles, cost share, denials, BS. And then what ends up happening is that the doctor goes after the patient. That's the unfortunate result of all this. They claw back, then the doctor says, no, that's on you, patient. Go fight with your insurance carrier to get you your money back. Otherwise, I'm going to send you to collections and put you in medical debt. And it's wild because they're pitting the two most important stakeholders of our system against each other. And it causes distrust. It causes abrasion. It's extra cost. Say that 30% of our healthcare spend goes to admin waste, pricing failures, and billing issues. For what?
The physician and the patient are the only two stakeholders that matter.
That's it. We need to get rid of middlemen, remove the middlemen. And what I was getting at earlier is that to do so, we need the tools. We need the tools in place to streamline that process. You know, the workflow that you're going through, that project with the hospital system, there are tools and information in place that should streamline that process, and it should take a matter of days. At least the bundling and the contracting could take a matter of days with the right information, with the right tools. And I think that's what I'm getting at when I talk about reducing the complexity and right. I don't think that it's as complex as rocket science. Some people may disagree with that, but the right tools, it's easy. Does that make sense? Like I think specifically,
the production of the data is not difficult. It's the decision making that comes from looking at the data.
I guess with the benchmarks, you know, we were talking about 100% of Medicare. You said 150% of Medicare. You know, hospitals, I think the NASHP says, 140% is the break-even point. I think obviously there's a lot of detail and nuance there that
it depends. That's a generalized approach, but
exactly,
you have to really look at, well, is this a 4-bed surgical hospital? Is it a 150-bed community hospital? Is it an academic medical center? Those are very different facilities, and their costs are vastly different. So to say that generally it's X, I think is it's not fair. Don't get me wrong. I'm no advocate for the hospitals, even though I used to run them. But I recognize that there's a lot of bad actors, and they're using a lot of poor talking points to defend themselves when they really should be looking out for the patients in their community. You know, especially since they're nonprofits and have a lot of tax exemptions to do just that, and still don't. But yeah, no, I think that we still need to look at it soberly and understand that there are different kinds of hospitals, and we need to compare apples to apples.
Yeah. And help them, you know, at the end of the day, what we're talking about, direct care, direct payment, helps their bottom line, helps them long-term. That 150% would essentially be a net positive for that hospital that was getting 300%, 45% of the time. And so, yeah, I guess when I say that it's easier than it should be easier than it is, and especially with the tools in place, that's what I'm referring to, is we have the benchmarks. We have an understanding of, you know, what the lay of the land is based on insurance contracts. You know, percentage of Medicare is the prevailing pricing methodology that I've seen since I've been in the industry. My entire professional career for 12 years at this point, most, if not all, insurance carriers negotiate and contract at a percentage of Medicare. And so for providers looking for a benchmark for what to charge, whether it be to an employer directly or to a patient through a cash price, you know, look at your Medicare, look at a percentage of Medicare, look at the percentage of Medicare that your insurance contracts are at. Because like you said, David, this is no different than those to some extent, right? The direct payment, the cash price is the same thing. It's the same pre-negotiated discount rate. as the insurance price, as the insurance discount price. And so use similar methodologies, use their playbook against them is how I refer to it with regards to contracting. Not that hard.
I understand what you're saying. I agree with some elements, but I do find that it's dramatically different. The direct to employer is very different than dealing with an insurance company. Why? Because the overhead associated with negotiating, verifying, billing, collecting, clearinghouse, it's a big percentage of your overhead. You are having to invest inordinate amounts of money in infrastructure to pay for services that you've already rendered. And then you may or may not get the money that is part of the negotiated rate in the contract, which sucks. So that's dramatically different from the direct to employer because you take care of the patient. It's agreed upon based on a contract or some level of agreement between the employer group and the facility. And then you get paid in 3 to 5 days at 100%. So you don't really have the infrastructure having to grow, at least. You're not going to get rid of it as long as you have insurance patients. But, imagine a day when it's all direct to employer and you're largely eliminating what the traditional insurance companies are doing today. How much more efficient and less costly will healthcare be? I look forward to knowing what the answer to that's going to be.
I think I could help based on what I've seen. So working with a few level-funded, self-funded health plans, getting a sense for what the decrements look like based on a pure direct-to-employer fee schedule or a pure direct-to-employer network, using the, percentage of Medicare benchmarks that are widely used, whether it's in the context of RBP or a PPO network. From what we've seen, I think on average, the level funded savings as compared to a fully insured plan is about 40%. But when you bake in the reduction of claim spend based on a reduced contract rate, a reduced negotiated rate, it gets even better. I expect to see decrements and savings of up to 60-70% on the plans that we're working with because, to your point, the admin goes down, the speed to payment goes up, which reduces the contracted rate because docs don't need to offset the billing cost with higher prices. And so you're able to gut a lot of the fat, a lot of the waste in the system. And I think we're going to see savings of 60, 70, 80% with the right tools in place.
That seems awfully aggressive. It feels awfully aggressive, but then I thought back to a Milliman study that came out a few years ago that said the amount of administrative waste in the healthcare system was close to between 35 and 40%. So if you're eliminating that altogether, there's your savings right away. And then all the things that we're talking about would be above and beyond that. So, aggressive, yes. Possible, potentially.
I think we need to be aggressive. And I think that's how we could close out because I know we're getting to be at time here. I think we have to be aggressive in this space with this opportunity. They left the door wide open.
Yeah. My only concern with I think we need to temper the aggressiveness. We need to seek out savings, and we need to do that quickly, and we need to do it substantially. But we need to also monitor. We need to also monitor the level of quality being delivered, because ultimately that's what healthcare is about. So those things must be married together. I don't want to focus on cost reduction at the expense of quality. But I think that's something that can be accomplished, but we need to make sure that we're doing it in a stepwise fashion.
Yeah, and I think it has to date. I definitely agree with quality not being forgotten. If anything, it should be the forefront. And I think that's what we've seen with a lot of specialty programs and a lot of these care navigators who are using reporting and analytics to drive patients to different facilities based on quality. We've seen the aggregation, or not the aggregation, the proliferation of a lot of these point solutions, care nav, specialty programs, direct contracting, PBMs, not PBMs, 340B, direct sourcing from meds. I think we've seen that stepwise approach take hold over the last, 5 to 10 years, more aggressively over the last 5 from what I've seen. And that's why I think it's time to take a bit more of an aggressive approach towards aggregating and rebundling those solutions in a way that drives meaningful and material and powerful savings. I think that 40% is just the average from what I've seen from these level funded plans. When you bake in a lot of the other, direct contracting at a comprehensive or in a comprehensive way, that's where you start to get real powerful savings up to the 60, 70%. And that's what I want to see, because that's what we deserve. It's been too long, 10 years with these high deductible health plans, putting people into bankruptcy. And it's time for a new guard, time for a new system, time for a new infrastructure, time for new tools. And that's how I'm going to end, because I keep going back to the tools. I think that's the big piece that's missing, or at least that could help accelerate this shift from our scam of a system, the train that's running away, to a more trusted, aligned, transparent system that I think we all deserve.
Can I say one more thing before we sign off, Sydney?
Please do.
Yeah, we talk about the runaway train. We call our healthcare system a lot of things. You've heard people say, "Well, we have a broken healthcare system." I don't think it's broken. I think it's working exactly the way it is. It's been designed to work for people that are enriching themselves in a dramatic fashion. It has been an engine that has been running their cash machine, and it is just spinning off.
They're printing money.
It's significant.
Evil.
So it's not broken. It's just we've allowed it to work in such a way, or allowed it to evolve in such a way that has taken away from those stakeholders that count, and it's made it more expensive, and it's made it more inaccessible. We don't need government to do more to fix the solution or to fix the problem that they've created in the first place.
Totally agree with that.
They have incrementally destroyed this industry, and the employers, I believe, are the key to fixing it. And they need to stop relinquishing in their power and deferring to state and federal government when they can be the ones to make the difference. It's just going to require some bravery, and for them to do things that are difficult. It's a challenge to do things new. You're afraid because you want to be able to recruit and retain your employees, but you've got to do some hard things if you're going to want things to change.
Totally agree. Thank you for that. I want to say one more thing, though, to that. Sure. Is the things are hard, and it's up to us as those positioned to support employers, providers, the two main stakeholders, employers, providers, patients. It's up to us to create the solutions that make it easier, right? Doing anything that's worthwhile is hard, but there are usually ways to help ease the burden. And I think that's what's missing. And that's what I look forward to us collaborating on to, help catalyze, streamline the process, and help us fix this problem.
Fantastic. Thank you.
Thanks, David. Take care. That wraps up today's episode of Off the Rails. Remember, you can find us on Spotify, Apple Music, YouTube, and other major podcast channels. Don't forget to subscribe to catch all the content. If you like what you hear, please leave us a review and share it with your friends. Your support means a lot and helps us deliver more authentic takes from real change makers. Follow us on Instagram at GoOffTheRails and follow me on Twitter at Sydney Haytalk. Thanks again for listening. Stay genuine and stay true.